All right. Good morning, everyone. We're just, my name is Natalie Neu. What? You can't hear me? Whatever you like. I've got a big voice. Good morning, everyone. I like to stand, it's okay. You know, being short. So, good morning, my name is Natalie Neu. I'm pediatric infectious diseases. We've met a lot of you. I'm so grateful to be here to work with you during this mission. Part of the reason why I'm here is because we realize that it's just so important for the success of the patients to control infection. So, and you have a very, very strong infection control program, but we're still suffering from a lot of infectious diseases and complications from infection post-surgery. So we need to understand why this is happening. And part of what we are trying to do is create a system where you can do adequate evaluation for infections and adequately or define why this is happening. So please interrupt if you have questions and try. So I want to start with a case to use it as an example of so we can understand some of the approach and maybe how we can modify the approach to evaluation and management of some of the infections in the patients in the ICU. This is a 7-month-old who has a history, and see, I don't focus on the cardiac, I just focus on infection. So a DTGA, had a switch, sorry for the spelling, a VSD closure, a ligation, had an open PFO. On day 1 to 2 post-op, had a cardiac arrest and then a respiratory decompensation. At that time, the patient was switched from the perioperative prophylaxis to colistin and amikacin. So we talked about this the first day, and I understand you have a lot of resistant gram-negatives, but that's using the last line of antibiotics for management on the first day of infection. So on that day, the patient had a positive respiratory, a sputum culture for Klebsiella non-Candida albicans. The blood culture was negative, and they added anidulafungin or Ecalta. So for a respiratory tract infection, maybe, probably colonization with Candida, we're giving an IV medication to manage it. The patient did better, got extubated, then went on high flow for support, was sort of percolating along, had abdominal distension a couple days after feeding. On the 20th, the patient had lung collapse, the white count, oh, they didn't finish the labs. Oh, wait. It didn't go on. I don't know. It's not matching. The CRP started at 20, and then I don't know. You can't see it on the bottom. Then the CRP went up to 113, and the platelet count dropped to 68 at that time. And how do I get it so that you can see that? On that day, they added it was already on colistin and amikacin, and on top of that, they added tigecycline, ciprofloxacin, clindamycin, and VFAC. So it makes me, as an antibiotic stewardship, want to cry, but at the time, on that day, you can see the culture was positive for Pseudomonas. And so then the question, came to me, what do you want to do, doctor? So it takes a lot to think about what we want to do, right? Because the patient's on the entire pharmacy here. So what we have to do when we're evaluating a patient in the pediatric ICU for suspected infection, we have to start with what is our definition. Everyone throws around sepsis. We feel like as infectious disease physicians, we always get blamed, oh, the patient died sepsis. Oh, the patient, this happened to the patient, it's sepsis. Sometimes it is, and sometimes it isn't. So we need to clearly define what sepsis means. The ICU doctors know this way better than I do, but sepsis is really a life-threatening condition and the body's response to infection that causes injury to the tissues. There's a specific definition of sepsis, so 2 or more systems that have been affected, or a confirmed infection or suspected invasive infection, plus cardiovascular or respiratory or other organ dysfunction. So this is a specific definition. It's not just like what happened to the patient sepsis. You have to have all these things together. So what does that mean specifically? That means that you have your infection, you do your blood culture, you've identified it, and you have these symptoms. You have a high white count, or you have like radiologic confirmation, for example, purpura fulminans. So you have to have criteria that meets this definition for sepsis. In pediatrics, there's other criteria that are evaluated. Again, the ICU docs can talk to this better. It's related to age. So the white count is related to age, the respiratory, the heart rate is age, and so is the blood pressure. You want to know, like cardiovascularly, is there hypotension? Are you adding vasoactive drugs? So if you're describing sepsis, you should be, as the doctor or nurse in the ICU, describing all these criteria that support your definition for why this patient is potentially in septic shock. In addition, if the patient is described to have pneumonia, the patient has to have imaging consistent with pneumonia. And this is difficult because heart failure can look like also pneumonia. So you have to also think about what are the vent setting changes. Is the sputum change? Are there white cells there? We like the CRP, but there's other things that indicate that the patient might have pneumonia, right? And then this is also specific by age. So in children, less than one of the criteria that's different is they can have bradycardia as an indication for pneumonia or infection. Oops, sorry. Too heavy on the fast forward. So what we met the other day, and we want to propose an evaluation strategy for the doctors and the nurses and the NICU, and the PICU to understand how do we think about infection and have a plan for infection. So define what what's going on with the infection. And I don't know why the formatting is messed up. I apologize. But is it sepsis? Is it pneumonia? Is it UTI? What you have, in order to decide what antibiotic you're going to use, you have to know where the infection is. You have to do a laboratory evaluation at that point, and then you're going to start your empiric antibiotics. We can create protocols for this, but of course, it's left up to the judgment of the physicians and the nurses who are there to also understand, use your own judgment in this situation, but we'll have a pathway where you can think about how to manage it up front. When you're deciding empirical antibiotics, it should be based on previous cultures or colonization reports. Prior to going to the operating room, every patient has a swab for multi-resistant gram-negative pathogens and also MRSA. This information, so that everyone knows, is found, which we found out yesterday, in the chart in the operative section. It's actually not in the culture section, it's there's an operative note and it's listed there. So you can know if the patient has MRSA, and that would indicate then, oh, maybe you need vancomycin, right? So you can find this information on the chart. You can also find the information in the laboratory section. So the cultures are there from this admission and also the previous admissions, and you need to have this data in order to decide what you're going to give. After you start your antibiotics, we would really like people to think about, do like a timeout, like what you do in the operating room. It's an antibiotic timeout to reassess. Is the patient responding? Has the respiratory situation got better? Is the CRP better at that time, right? Resend your blood culture. Has the blood culture turned negative? And then at that time, establish, if the patient's not completely better, you have to think about, Is this the right antibiotic? Do I have the antibiotic that's going to get to my source of infection? Do I need to change antibiotics based on my culture report? It's not just adding and adding and adding, because adding and adding causes a systemic problems for the patient and is driving your problem with resistance in this hospital and in this nation in general. And we can be the ones who start the process of controlling antibiotics. We can start that process here by using a logical, critical thinking when we decide how we're going to prescribe, and not prescribe with fear. We prescribe based on data. We need to establish an end date as well. It can't be somebody stays on antibiotics until they leave the hospital. We cannot do that. We have to establish an end date for these antibiotics. Can we rely on this protocol? Does this make sense? Does the blood culture, can we rely on our blood culture results? And the answer is yes. We went to microbiology. Everyone knows the doctor from microbiology, right? So the team here. So we looked at some of the results over the last month. So in the beginning of October, one patient had a blood culture sent on the 1st. Almost within 8 hours, that blood culture resulted positive. What is the response? Microbiology calls the ICU and says this patient has a positive blood culture. They, in addition, send a message out over WhatsApp to the team so that everyone knows what the blood culture is. They identified it as a gram-negative rod. So you know, okay, this is where I need to start. This type of antibiotics is going to treat a gram-negative rod. Literally 2 days later, they have identification and susceptibility. In the US, we don't have susceptibility done within 48 hours. So this is very, very good. We looked at another case where the patient had a blood culture on the 21st. The result came back positive on the 23rd as gram-negative rod. So you can see within 48 hours, if the patient is septic, if the patient has bacteremia, you will get your results. You don't have, it's like, the reason why people say you have to wait 5 days is because the culture will be finalized at 5 days, right? So they won't hold it anymore. There are some exceptions where you might get a late culture positive, but this is, you can rely, if you don't have a culture in 48 hours, it's likely that you're not going to get an organism. So as I just mentioned, most blood cultures will be positive within 48 hours. So this should drive your policy about how long you're going to keep antibiotics. So our policy in the US, and I'm not saying that you have to do this at our hospital, and we're trying to drive this point. If the culture is negative in 48 hours, you don't have an answer, you don't have pneumonia, you don't have a UTI, you need to stop antibiotics. Yes, the CRP may still be elevated, but there may be other reasons that the patient has an elevated CRP. There are some shortfalls with like this process in the 48 hours. We can't put the organism in the system. We learned the other day that we can't totally confirm. It's a IT problem. So the data is there. The lab will give the data to the physicians by the WhatsApp. You can walking down to the lab and talking to the microbiologist. It's literally you get your steps in, you just walk down, you walk up. It's not that far, it takes 2 minutes. I think Olga, our pharmacist, timed it. You can get the data and so you can know what's there. I think the only reason why you might have a delay and where sometimes there's a problem is when we have a blood culture bottle problem. This happened last week, which we identified, and maybe people didn't know, but the microbiology will send a message through the WhatsApp and tell the team, we ran out of blood culture bottles, and so therefore the cultures cannot be done in-house, they have to be sent out. When this happens, this is why you have the delay in cultures. Then you don't get the culture back for 5 to 6 days. And this is definitely a problem. So how the other issue when you have a delay in cultures if Candida is there. Sometimes Candida takes a little bit longer to grow. So it could grow like within 5 days. So you have to look at other supporting data that if you have a suspicion for candidiasis, you have to look at other surrogate markers. If you're gonna have a multi-drug resistant organism, you might have a little bit of delay in getting your susceptibility. That's because they have to do, instead of using the BAT test, they have to use an E-test. So if you remember back to medical school and nursing school, they take the disc for the medication, they put it on the plate, they look at the clearance of the pathogen. So this is the only time, this is when we're looking for the colistin resistance. And then if we need to look for other other antibiotics, so extended spectrum like aztreonam, ceftaz, avicat, which hopefully maybe we'll get that for our MDR drugs, then that has to get sent out, and then you're going to have an Uber delay. So these are the cases where that might be delayed, but you can have that discussion with microbiology, and I would really encourage you to do that. Like, what else can we do? What else can we test for? You know, why is this happening? That's very important. The communication piece is critical. You have to establish end dates for antibiotics. So sepsis, you know, no source, maybe 7 days. Maybe we can go to 48 hours eventually, once you feel confident in this process, right? That might take a little bit of time. Bacteremia, there are defined length of times for treatment for bacteremia. So gram-positive, gram-negative, it's 2 weeks. If you don't have a source, if you have endocarditis, that's different. If you have an abscess, that's different. If you have, like, you know, an abscess in your lungs, maybe you need longer. But it's not 60 days and then add another antibiotic. So I just want people to think about that. There are oral options, like, so if you do need to have an extended course, so you're treating mediastinitis, there are oral options that are well bioavailable, but it depends on what your organism is, whether we can actually do that or not. So the other thing we need to talk about is management of the positive blood cultures. And this is a little bit of shift for consideration for your policies. So if you have a positive blood culture, oftentimes we're not repeating it. And the problem with this is that we don't know if we've cleared the line, right? So your blood culture was, if your bacteria is stuck on your line, you know, it's in the catheter, then, and you're doing, you're not repeating your blood culture, you're not gonna know if that source is clear. So I would recommend that you repeat it at like 48 hours to see, especially if the patient is not getting better, to see whether the bacteria has cleared. There are certain conditions where, as an infectious disease specialist, we recommend taking the line out. So fungemia, so if you have Candida in your blood, we recommend the line removal. And I know this is very, very difficult, but it's a conversation that you have to have. It has to be a consideration, because Candida and gram-positive organisms, they create these biofilms, and they love to live on stuff. So they will live on your catheter, and then they will live on your Gore-Tex or your patch that you put in your heart. And that is going to create a lot of problems. So if you have persistent bacteremia with staph, you're going to get endocarditis, hands down, and your repair is going to fail. So that to prevent that, you have to do line removal, right? So just think about this. So there's also a discussion about, you know, when is this the patient a good surgical candidate? There's a lot of patients who need to have surgery, who can't have surgery elsewhere because this is the place to go, and there's just a limited daylight to be able to do the surgeries. So people come in as emergencies all the time, and we're not sure, like, is it safe to take them to the OR? We want to establish criteria where you can consider whether they should go to the OR. You need to do your history and physical. And we were saying the other day, a cardiologist does one type of history, but for us to know if it's safe, you need to know that they're clear for infection. So you have to do an infectious disease type of evaluation. Has the patient is the patient free of infection? No fever? Is the white count? So you need to send some labs. Is the white count normal? You need to send your surveillance cultures. Has the patient been at another hospital? And I understand you don't feel like you can rely on your culture results, but just having the data may be useful. We can confirm that here, but it's a good place to start. And there should be better communication between the other hospitals and here to be able to support your decision making. If the patient doesn't have a high white count, if the patient is, the CRP is normal and the patient has a critical cardiac lesion, then the patient can probably go to the OR that day. But if the patient is sick, if the doctor feels the patient is not ready, you can wait. Start the patient empirically on antibiotics, give yourself 48 hours, like our protocol, reassess. If the patient has improved and is stabilized, it's much better then to go to the OR, much safer, because you're less likely then to have the risk of sepsis at the time of your operation. You can't see the bottom of the slide, so I'm sorry about that. I don't know what happened. Yes.
There's a difference in the line, the dressing changes from the US to here.
Yeah.
And there's, I mean, I'll have the nurse speak to that, what they do at home versus what's done here. And I think that there may be, you know, some sort of opportunity for infection with the frequency of, you know, dressing changes or the timing from the OR. But anyway, can you just, one of you guys just speak up about what they do, what you do at home versus that? I'm just concerned about that could be a possibility for infection. So
yeah, I have a thing.
So what do you go ahead? Do?
Everyone. My name is Khadija. I'm the ICU nurse back. So our protocol is post-op is we take the sternum incision dressing down next day. And reason why is just to inspect surgeons orders to and make sure there is no the area is intact. So if it's completely dry, we still use betadine. We don't necessarily cover it unless we have to. And as far as the line, we don't touch them unless they're soiled. And also, we use chlorhexidine, which I don't know, every institute is a bit different, but we don't touch them unless they are soiled, just to limit access to the lines and introduce infection. So that's what the standard is.
What are you observing here?
So what we saw, they take all the line dressings down right after post-op and they clean them with saline, which I don't know, like what I say about that. So
It's probably not the optimal for removal of any kind of bacteria or skin flora. I think that might not, do you want to speak to that? That there's not the policy that's actually here, right? So what is the actual policy here?
I think about when we talking about the wound management, we are
The line.
line.
Yeah, line.
Okay. The line we use Tigader. It's a transparent dressing. We are looking for losing or dumping or something like pus at insertion site every shift with the nursing. If there is, we can change this dressing immediately. If not, we can stay on this dressing for 7 days or till we pull it out from the dish.
And how do you clean the site? What's the recommendation for
We
cleaning?
are cleaning the site when we doing the care of central line with chlorhexidine or betadine under a certificate.
Is there an ICU nurse here?
Local.
No, local. No? No, I see. Okay, Doc, what about the doctors? Is that what the nurses are doing?
Mr. Ray can give this. As the trauma since our policy here, we are changing the dressing when patient need. There is oozing,
Yeah.
remissions, we are using the or chloroquine. The changing dressing policy is after 7 days.
No, but the cleaning of the line at the site,
We need it if there is bleeding or oozing.
Change the alarm dressing. Using saline. Contact time. And then
so they're using saline.
line.
So that's the whole point. The point is that probably saline is not the thing you should be using, and the policy says chlorhexidine. So we need to maybe re-educate on the policy and have more training around
You
it.
meant there's no need for saline? No need for saline? Is it clotting or blood clotting? No need for saline?
And then-
Washing.
I think we are enforcing using saline after betadine,
After what?
after betadine contact time. We have to wait
So but betadine first and then saline.
as a saline, as a wash. For that.
So it doesn't appear, I think we're getting different information, and this is why communication is important. We need to sit down, look at the policy, and then see what the team is actually doing.
Okay.
Yeah. I think I might have given you the wrong slides, but in general, like when you're thinking about antibiotics, I was just, because it's not everyone's like frame of mind. And for the doctors specifically, if you wanna ask me about antibiotics, this is the information I need. So if you wanna be my fellow, this is what I need. I need to know, when did the patient go to the OR? What was the perioperative coverage? What is the history of infections, antibiotic use in previous cultures? What happened during the ICU? On what day? What is the trends of the labs? What kind of evaluation did they do? CRP, chest x-ray, and then look at the antibiotics, and not just looking at susceptibility, but also looking at what's listed as resistance.
As per your surveillance, did you recommend using saline
For what?
for line treatment?
So the line care, what the nurses are telling us, right, is that, Khadijah, you guys are using chlorhexidine or betadine?
Only
Okay, we are using here betadine.
Yeah, so it's, you have to, like, betadine's fine.
I recommend to use a saline wash after betadine.
Yeah, so it's saline wash after betadine.
Yes, it's our policy here.
Yeah.
I ask about your experience.
Chlorhexidine.
Your team experience
Chlorhexidine.
only.
Chlorhexidine and betadine if they have any allergies or
Yes,
Or allergies.
So you use the line for
If allergies. For allergies.
Please, doctor, saline is not like very change on the ingredient
I
betadine.
can't hear you.
What's the problem?
Asking about if saline can cause any change in the composition of the
After
betadine or
betadine, I think we change the composition of the betadine after.
So you have to let it dry. So that's the whole point of like hand hygiene and using these products is that you have to let it dry. So when you're using like the wipes that have the either Clorox or anything, you have to let it dry. It's like the dwell time that's on there. So the betadine, you actually have to let it dry. You can't just go and then you're done. That's useless. That is like, just like, you know.
Even after waiting time for betadine,
Yes.
they may use dry water or saline.
So they're using saline, right?
Saline.
Yeah. But it should be sterile,
Yeah,
right?
sure.
Yeah. So. I'm missing some stuff, one of my slides, I don't know why, but this is back to our case. So when this patient came back, the blood culture was positive for Pseudomonas. And here it says the sensitivities are the piptazo levo as resistant to ceftazidime and cefepime and amikacin. So in this situation, this is so important that you know what the resistance is, and it's at a different level than probably you wanna know. But resistance to the fourth generation cephalosporins indicates that this is an AMP producing organism, which means that it's gonna create resistance and your antimicrobial is not gonna work. So you have to pick a carbapenem. So that's why we recommended starting meropenem. We also recommended leaving on only one antifungal because the platelet count was dropped while we're waiting for the blood cultures to come. Because that's using surrogate markers to understand whether there potentially is a fungemia. If this patient had been on antibiotics, so what are the risk factors then you have to think? Could this patient have fungemia? Yes, they've been on the broadest spectrum antibiotics for 21 days. So once you kill every bacteria in your body, what's left? Fungus or Stenotrophomonas, right? So those are the only thing that's left. So this is what the problem was. So we discontinued everything and then we went on those two drugs. So, you know, it's not like cooking where you just keep adding, oh, I need a little bit more salt because it doesn't taste good. Like antibiotics don't work that way. They're very specific for the organism, they're very specific for the site of infection. It's really important for you to, to understand those things and adapt. I had one other, and I don't know, I think I gave you the wrong slide presentation, but there, oh yeah, no, yeah, there, okay. Yeah, so go down one more, yeah. So this we did, so number 19. Yeah. So there are guidelines that you can use to decide antibiotics, and it'd be really nice if you had an infectious disease specialist, because it's not, you know, I'm not gonna go do heart surgery. So I wouldn't expect you to know how to manage some of these uber complicated infections. There are guidelines from the Infectious Disease Society of America, for example, and there are difficult to treat Pseudomonas guidelines specifically. Oftentimes though, you don't have those drugs that are there. So there are new drugs like the Abicaz, ceftolozone, tazobactam. So there are newer drugs that are out that are not quite available that we have to think about, do we need to get them? But my concern with getting them is that you're going to use them indiscriminately, and that we can't have. So they're now, like in our hospital, those drugs are restricted. Like you can't get it. Can you imagine you would have to go through me every time you wanted an antibiotic? You would all be tearing your hair out. But that's how we manage antibiotics in our hospital. So if you want some broad spectrum, if you want anidulafungin, if you want anything beyond Zosyn, you have to call me. And I have to say, doctor, please tell me, how is the patient? What's the data? Give me your case. It's like going to court every time. Poor doctors. But the other thing that they have in the guidelines is really, there's no role for inhaled antibiotics in somebody who has pneumonia. All you're doing is basically treating yourself. That's putting antibiotics in there to, like, you know, it's like the scrub. You think you're scrubbing it, it's gonna come back and you're creating resistance. So whatever pathogens that are living in the lungs, you're giving the inhaled antibiotics. It doesn't work systemically. It just like sort of scrubs that culture for the moment, and then it comes back. Oy, I have a heavy finger. So the policies that, here, you can just read it here. The policies that we are going to be talking about potentially, and we should reevaluate over the next several months. One of them is the perioperative Hep C protocol. You now do testing for Hep C. There is, if somebody has antibodies that are positive, you need to know if they have active disease. This is very important for our surgeons, because if there is an accident or there's blood exposure for the surgeons and the nurses and the people in the OR, we need to know if the patient has active Hep C. So with potential, we might be discussing doing a reflex PCR testing, maybe for pediatric patients. We're evaluating the cost effectiveness of potentially instituting that program. The other thing that we talked about is having all of you understand where are the culture reports. And also making sure you look them up. And as I tell my fellows all the time, don't tell me something doesn't exist if you haven't looked. So if you have looked and in your heart you can say, I have looked and the culture isn't there, then good. But don't just say, no, the culture's not back when you haven't looked, okay? Because that's bad medicine. You have to be actively looking. Perioperative antibiotics are super important for us. We noticed that it's potential that we're not covering the pump. So the pump requires its own antibiotics because that's a lot of blood when you think about it, right? So the pump needs to be primed with fluid, but it also needs to be primed with antibiotics. So I think one of our anesthesiologists was talking to people in the OR and the perfusionists about giving another 25 milligrams into the pump to prime the pump, and then redosing antibiotics every 3 to 4 hours in the operating room. When you receive them in the ICU, and the nurses in the ICU should be like, when was the last dose of antibiotics in the OR? We need to give the next dose 4 hours after that. So and I know mostly we're concentrating on the heart and making sure that the heart is working well and the patient is breathing, but don't forget that because that contributes to your sepsis, right? And then we're going to stop those perioperative prophylaxis in 24 to 48 hours. The operating room policy, we're going to talk about this a little bit. Is it potential that there's sources in the operating room or other places that could lead to sepsis? There's a heater cooler machine that's in there that was involved in epidemic of infections in the United States. So we need to look at the policy of evaluating that heater cooler to make sure and surveillance cultures of that. And I'm sure there is a policy on that. So we're just going to review that to make sure that that's okay. In the ICU, there's a lot of places where we can relook at infection control and infection prevention. We need to relook at maybe the open chest coverage protocol potentially. We need to maybe amend our wound care or chest protocol. And we need to also review all of our techniques for medication prep. So in the pharmacy, you should be doing the medication creation like in a sterile hood. When you're administering the medication, you have to scrub the hub. You also shouldn't rely on only that central line. You might need to put in peripheral lines for access because the central line is a huge source for infection. And the minute you don't need that line, it should come out. So there is a policy for every time you go into the line, you're supposed to scrub it with alcohol. Do the alcohol pads exist next to the bedside? Have we seen them? Not reliably. So maybe they need to be moved from where they are on the outside of the patient's room to the inside, maybe where you're administering the med. So these kind of like infrastructure, like protocol things, these are easily changeable. We just have to like put it in place so that it's just knee-jerk. Oh, I'm going to open the line. I have to scrub it. I have to wash my hands first, actually, and then scrub the line and then do the thing. So we need to do that. And then patients they shouldn't stay with a central line until they get discharged. We need to think about pulling the central line, leaving them with peripheral access if they need it, and then they go to the floor. And if they can take oral meds, switching to oral meds. So anything that's plastic, anything that's a foreign body is a source for infection. If we can eliminate that, we will improve our sepsis in these patients.
Is there a protocol of connecting the central line from the ICU to the ward?
There is. I don't think a central line should be going to the floor. The central lines should be out before you're getting discharged from the ICU, and a peripheral line needs to be placed. It's not safe. And then the floor nurses are accessing the central line. That's a source for infection. You could put a PICC line in. And we talked about potentially maybe creating a training program on like a PICC line is a longer IV, so you'll be able to have central access that way, and there's a much lower risk for infection.
The difficult condition, we have many patients who are still to the ward with the line. So what the alternative techniques are using?
Put in peripheral IVs. Or put in a PICC line.
This is difficult condition.
What?
Difficult condition.
Difficult condition? What?
Difficult cannulation for peripheral
A hard stick.
Yeah, well, you know, y'all can learn how to do that. Like, there are also machines to look, to see. Yeah, but, yeah. I know, I don't do it. I think I put in one IV my entire life, I have to say, as an ID person, so I can't really speak to that, but.
Totally agree with you that transferring patient from the ward to centralized physical for the patient. And I think for our stuff, ward stuff. Maybe unsafe dealing with centralized ward.
So I think maybe one thing to do is create an IV team. So in our hospital, we have a team of people who specialize in line placement.
What about this line?
They specialize in PICC line, they specialize in peripheral IVs, which is why a lot of our residents can't put in IVs anymore. And usually it's actually the nurses in the ICU that put in the IVs. So, and they have the most experience. So if you do it, you will get like better at doing it. And that'll, you know, and maybe you just create a team that is their job, you know, they can work with IP&C and an evaluation for the lines, and they can also be the ones who are putting it in, like, I think.
For me, transfer patient, the ward with centralized.
I am not your hospital policy creator, but,
No, in your hospital.
oh, in my hospital, patients go with Broviacs, not central lines, I don't think are there central lines on the floor?
Very, very rarely.
Very rare. But in our ICUs, the patients will have an art line, 2 or 3 purple IVs, and central access. Yeah, so they have a lot of lines. Yeah, questions? Yes, sir.
What about source of lab from ward, not from ICU, source to home? If the patient has gram-positive or gram-negative infection, we start antibiotic according to the initial result of the culture. We should withdraw a new blood culture after 48 hours of the starting antibiotics and wait for how long after changing the antibiotic?
So how long does it take for the culture to be positive? It's gonna be positive.
I think maybe 2 days or 3 days.
You are absolutely correct. So if it's negative for 2 days, you can say that it's probably gonna be negative 95% of the times. But the patient who has a bacteremia has to get IV. There are very rarely are there criteria for doing short course IV to oral switch. So like uncomplicated gram-negative bacteremia, which none of your patients meet that criteria. Uncomplicated staph bacteremia in a heart, no way. Oral, no way. No bioavailability, so for the antibiotics, so it has to be 2 weeks of IV. 2 weeks. Most infections, it's 2 weeks.
And then, what's the polling protocol?
Yeah, we looked at the Foley, like the median time for having a Foley catheter in, it was 4 days.
5 days.
5 days. That is too long, and it increases your risk for infection. So.
We don't use folic acid. We are using silicone. Silicone, yes, not folic acid.
Is it a tube that's inserted into the urethra?
Silicone.
Okay. A silicone catheter. It's a catheter. So a catheter that's in the urine, it's the same thing. It's a foreign body.
But the risk factors from the folic acid is higher than silicone acid.
Okay, but it's still a foreign body, and it's still a source for infection.
Told us that the technical care may take longer than the folic acid and the risk of infection. So we, from the start, we also said.
But why do you need it? Why do you need to leave it in? If the patient has adequate I's and O's and you can measure it and the blood pressure is stable, why do you need a Foley catheter? Because you don't want to change the diaper. Like, like. For me, taking everything out like plastic.
I think this removing talking about critical patient, critically patient.
Oh, critical, yeah. If you can't follow their ins and outs, and if they're on like blood pressure support, you have to leave it in, no problem.
But
No problem.
patient can still wait after 2 hours, so even 1 hour,
Yeah,
one day.
we just want people to think about removing sooner.
And I think removal of central cervical cat depends on patient condition, the patient mobilized, extubated, mobilized, so
Well, you
we can,
can be extubated,
we can remove
like-
as soon as possible.
Saw a lot last year of patients ambulating in the hallway with their catheters still in. So in the US, if they can be up and moving and get to to get out.
So you can remove the patient, remove the folic acid or silicone when patient intubated.
Yes. Some cases, yes. Usually all of ours we took out with extubation.
We need to check our policy. Because
The policy is a guideline, right? So obviously, we're saying that what we want to do is minimize the risk of infection. And each case is different. We don't want to take away the critical thinking. We want you to increase your critical thinking. We don't want you to just be robot medicine. You're trained. You can critically think. We want you to take the information, digest it, and it's like going to court. Make your point, give your data, make your decisions. Yeah.
Okay.
So guys, this is still on the table. I want to just strictly monitor the fluid balance. I may need this urinary cat, but after that, even if the patient is not extubated yet, I can remove it if the patient is stable.
Yeah.
This is the thing, because in some cases, we can use it for many days, because the patient is still critical, needs strict fluid balance.
That's again, it's the art of medicine. It's the art of healthcare. We're not removing that from you. We're providing you guidance about how to consider some of these things, always keeping in mind, what am I doing to the patient that could increase the patient's risk for infection? And will then ruin all the results that you do in the operating room if the patient has an infection.
CDC recommend to remove silicone cast according the clinical condition of the patient. And infection parameters. This is what is written in the policy and CDC recommendation. According to the clinical condition.
Yeah.
Measuring urine output.
Yeah.
The patient hemodynamics, patient internal has source of bleeding. So the main course clinical condition of the patient.
There isn't a time of the original time to put it.
The other thing I want to just remind everyone that like the use of prophylaxis antibiotics, like for central lines or for chest tubes, doesn't need to happen. Like you don't need to prophylax those. Leaving somebody on antibiotics just because they have a chest tube or because they have a central line, that is not required. What is required is that the nurses take good care and the doctors take good care of the central line. And be vigilant.
You said that no inhaled antibiotics, but I think there is some data about cholesterol.
So he's saying there's some data for colistin inhalation for treatment of pneumonia?
Maybe pneumonia complication at cystic fibrosis.
Do your patients have cystic fibrosis? Oh, okay.
We don't know. But if you have isolated pneumonia, not cystic fibrosis, can we use steroid? Cholesterol? Inhalation?
I don't, it's like detergent. How colistin functions, it's a detergent. So it's a membrane breaker. So you're basically putting detergent into the lungs. Is it gonna work systemically? No, but you're basically putting detergent in the lungs. It's not the treatment that is recommended. Some people use it for, and now we're getting beyond, but for prevention of infections in the outpatient setting, in COPD, which a 4-month-old is not gonna have, or in cystic fibrosis. And the reason to do that is more to decrease the colony counts, so detergent, decrease the colony counts to prevent that person from getting a serious bacterial infection. So your patients are colonized. Your ET tubes are colonized, for sure. But giving them that medication is causing resistance. It's not treating the infection. It's treating you. But, and it makes us feel good because we're doing something.
So
But-
even hyperlights also inhalation.
No use. Yeah. Unless you have COPD, cystic fibrosis, in a setting of, or you want to prevent infection to decrease the colony count,
Please, in your hospital, do you,
as far as I'm.
if you draw a central line, a cat, you send it for culture utility or no?
Then capture.
Oh, taking the central line out and sending that for culture? No, absolutely not. Yeah, that's like taking your Foley out and sending it for culture. You're gonna grow everything. And we don't wanna know. Oh, that's the other thing. If you remove your line and your line is infected, we do not want you to put a new line in, because what happens? When you pull that line out, the bacteria are like, yeah, free. And they go all through the body and they land right on that new line that you just spent 4 hours putting in. So if you can, and sometimes I know it's absolutely not possible to not do it because the patient is so critical. But if you can, wait, take a deep breath, put in 2 peripheral IVs, give everything peripherally, and then put in a new line. If you're trying to treat that central line that's positive, you have to put the antibiotics through that line. If a patient has multiple lumens in that line, you have to put it through all those lumens. That's the only way you're gonna clear the line. Yeah?
The situation here, sometimes we are looking for sick patient, and anthropic support, program switch مثلا. And central line is infected. What's the best scenario or best case scenario at this case? So we need to remove central line
So it
with this
depends.
anthropic support.
Give a quick line.
Quick line.
Yeah.
It's not ideal,
Yeah, I know.
but yeah. And there are cases, so saving the patient is the goal.
Are facing this situation, sometimes patient anthropic support and line more than.
So I would give antibiotics through the line for at least a day or 2, and then I would pull the line and put the other line in. Yeah. If you need to do it, you need to do it. We've done exchange actually over a wire for a line that we couldn't clear. Like you have to use your clinical judgment. If you can't do it and you need to do it, then you need to do it. But ideally, the ideal situation. Move the line. Okay, yeah.
Any, clarifications that you see between your observations from starting from the process, you know, that I see, maybe we should all be aware of, that maybe should be changing.
I think that we can all do a lot better on several fronts. So one is hand hygiene. That's the basic. So every time I walk into a room, I think and I always think if I'm the patient, if I'm the mother of this baby, do I want that person touching me? Have any of you ever gone to the doctor? Do you want that person touching you if they didn't wash their hands? They just went and had falafel and they come in, right? So you don't want that person touching you, right? You're the mother, you don't want that person touching you. So what I do before I walk into the room, so they see me, on the outside, I do it, I'm free. And I keep my hands like this, I don't touch anything else. Then if I need to, I put my gloves on. When I take my gloves off, again, every time, if you touch the monitor, don't go touch another piece of equipment, don't go touch your central line. That monitor is caked with bacteria. You have to wash your hands. If you touch it with your glove, you have to take your glove off and wash your hands. By the end of the day, your hands, if you do the Purell 10 times, you have to use soap and water. Right? And the only time you have to use soap and water is visibly soiled. Right? You have to use soap and water. Or somebody who has C. diff. Because you want the frictions to get rid of the pathogen. So hand hygiene, critical, critical, critical. Like your hands should be like, at the end of the day, you're like, oh my God, I can't wash my hands another time. And if you're not like that, you're not washing your hands enough, okay? The second thing is really the line management. You can't go into your central line every hour, every 2 hours. It can't be your only access point. You have to use the alcohol, and it's not just like this, you know, like, okay, I'm watching the central line. It's like this. Right? So you're scrubbing, everyone scrub their floors, right? Same thing, you have to like scrub it. Our nurses can give a demonstration of what they do, how they do it. It's pretty aggressive. Yes, Khadija.
So, I'm such a client, but, what's your policy? Is that every 2 hours flush the central line with saline? Is that what's the practice, right?
So is the policy every 2 hours to flush the central line?
Every hour or every 2 hours, the central line flush? If
Every
there's
2 hours.
nothing,
Every 2 hours.
Every 2 hours for central line flush.
so, like maybe limit that instead of saline, maybe heparin instead, and you don't have to access the line every hour or 2 hours.
Regarding the heparin lock, we don't have policy here regarding the heparin lock. We are thinking about heparin lock, right?
Yes.
We don't have it. So we can arrange with the infection control and the ICU consultant to use the heparin lock. I know that there's some countries using the heparin lock for center line. But here don't have, because sometimes patients heparin infusion. So the indication or use of heparin lock may be a risk for this patient. So we need to arrange Dr. Moshat and
But
infection
you-
control, the use of heparin. And sometimes there is some look for TBN also. Yeah.
So the amount of heparin that goes in is tiny.
Yeah, very tiny.
It's only to cover
Just
that
the line,
plastic.
just for the line.
We can discuss because we are starting since 2 months ago the use of antimicrobial look for killing of
Can we add some like antibiotic on the
TBN.
look it?
We don't wanna do that, having an antibiotic lock, it's gonna create resistance. So there's only special cases, especially the kids with TPN, the GI kids, that we do it, because they need their central line for life, for TPN, and they always have translocations. And so in some of them, like in our hospital, we do some antibiotic lock.
Yeah.
There's also ethanol lock that we're gonna talk maybe for outpatient.
already we start antimicrobial look for TBN.
Yeah.
But regarding ethanols or heparin, we don't implement it yet. So we can arrange with the infection control and the Dr. Donia and Dr.
Yeah.
Mosad
Yeah.
the process of starting heparin look.
Yeah. Other questions?
What else? What else have you seen? What
Everyone
else?
wants to join the infection control team, right?
What about the operating? The operating.
So everyone wants to learn, so part of the problem in the operating unit, it's too crowded. There's too many people in there. So more people opening the door in and out increases, it's known to increase your infection rate. The preparation for the pumps and using unsterile supplies like scissors, touching the tubing, then cutting it, and then connecting it to the patient. Not awesome. That, if you're using an unsterile scissor and you're cutting a tubing and then you're connecting it to your perfusion pump, that's an unsterile line. So I think we just have to, when something is sterile, we have to always be thinking how to keep it sterile. So sterile scissors, don't touch don't touch it with your dirty glove. The glove is not sterile. So there's a lot of work that can happen in there as well. It's a team. It's like there's so many points, and each of us can play a role in helping to control the sepsis. If we just every single time think about it.
Is there in your practice, do you have any concern about having the two patients in one room, like a double bed? Is there a protocol or something?
Yeah.
Yeah.
So the question was, is there a concern of having two patients in a room? There are criteria for how far apart patients need to be for infection control purposes. I think it's about 6 feet, 3 meters, 3 meters. The other thing that people think about is,
Droplet infection or even vaccine infection, whatever infection,
yes.
whatever.
Yeah.
Types of infection.
So the question is, how far apart should patients be in the room? Can you have 10 beds per room? No. At least 3, at least 3 feet. The problem too with having multiple patients in the room is that patient goes to you and then goes right to the other and doesn't wash their hands. Because the Purell is on the outside.
Yeah.
And so.
But if we have two patients in one bedroom, I may sterilize my hand, but the relative, they always touching each other and they touch the other object, the other bed. No control inside.
So, the team can work with the so in the US. Parents are everything, right? And many of us are parents, they help with soothing, they help you. They help with calming the baby, they help with providing love, they can help you with cares for the babies, right? But we have to teach them how to wash their hands well. We watched the nurse teach the family how to do hand hygiene on the floor. Fantastic. This mom had it down. So they were teaching them very, very well. We can start teaching them in the ICU as well, how to do hand hygiene. There's a lot going on in the ICU that's not exactly something that nurses are gonna have time to do, but we can maybe get support from others to help do that. But I think that there should be rules for the parents, the parents should be able to touch their own child, but if they touch the counter, they shouldn't touch the other patient's bed at all, ever, and they shouldn't touch the other baby at all, ever.
But there is no comment between them.
No parent at the ICU.
Parents are sleeping in our ICU. I know that makes me cry.
I suggest
Sometimes the baby is
So? If you have babies, if your baby was intubated, would you want to hold your baby's hand? Yes, okay.
Wear the mask, the gloves.
15 minutes is not enough.
15 minutes is no time for a patient who just underwent critical surgery. It's heart-wrenching for us, but you have to do what you feel is right for your population. I don't know that it's the parents that are increasing the infection, honestly. I wouldn't blame the parents for infection. I think we should look within and at ourselves. Right? I think the parents have been through enough. It's not gonna be them who's bringing it to the baby. There's so many other things we're doing to the baby. It's us. It's the institution, it's the invasiveness of what we're doing.
I think what Shireen was saying is I think what Shireen was saying is actually very important if you want to move forward. In the sense that if you can come with one changeable measure in every area that we focus on for the next maybe 3 months, and then do an audit, and then we come with the results. But one single measure for every unit, I think that would be an important point, because we don't see us, you see us,
Yeah.
when we do everything every day, we don't see the minor or the major problems, because it's becoming a daily routine. But when someone from outside comes and observes us, this is where your input is very valuable. But if we try to change so many variables all at the same time, that would be very difficult. But if you change one variable in every area in collaboration with our local team, and then after 3 months, we communicate with you and with Shireen, and we come up with whatever measurable quality points that I think that would be a good point.
So you wanna be a champion, right?
Yes.
Champion, right?
I'm the electric. I think I'm the electrician in the room. I'm the electric technologist. I don't.
It takes a village, it's everybody. So you can help. Yeah, I mean, I think that's a great idea that each team can create a champion who can be in charge of creating, deciding what do we want to work on. If it was me, I would definitely think about the central lines, because I think that that's a big problem. And then hand hygiene is so easy. It can't just be everyone's looking at me and going, she's coming, wash her hands. It has to be all of you who like sort of help each other and correct each other. Great point.
Can't consider punitive, like, I had a situation where I watched a physician go from an isolation room, but not here in Costa Rica, take their lab coat off, put the lab coat on the bed, go back on, go outside, put the lab coat on the other bed. I said, oh. And I said to the nurse, if you ever see that again, you tell him that's my patient. She said, I can never do that. Oh my God, that's the doctor, I'll get fired. But you have to let the nurse speak up and say, that's my patient. The patient, she's the protector of the patient. They have to be able to say, doctor, sorry, you didn't wash your hands, would you please wash your hands? You cannot, with your egos, get in the way of patient care. And this is every single country I go to. The ego is the one thing that is the obstacle to progress in every institution. So park your ego at the freaking front door and then come to work. And pick up your ego before you go home, but maybe not so much for your wife or your husband. That's just a good idea. But put it someplace. But ego, think about that. If somebody is saying to you, please doctor, don't get like, oh my God, how dare you speak to me like that? You say, oh, you're right, should I forgot. I forgot, you're right. Shukra. Say thank you. Shukra.
Yeah.
And then you do your thing. No, seriously, you guys, and I'm a Muslim Australian. And I'm telling you, I threw up. I coming here and I know the culture. And I know the culture there in the United States, but I'm telling you, the one thing is ego. It's getting in the way of you guys have such an amazing program.
Yeah.
You have the most educated, academically educated nurses I've seen in my over 20 years of doing this, from all the countries I've been to. You have so much going for you. So you have to work as a team. You have to remember to not let the fact that I'm a doctor or I'm a nurse and that she's not is a higher nurse than me, she can't talk to me. No. Nobody says that, just be your part of the team, and those kids need you, and the more safe kids, they're all going to heaven, okay? So you just need to you just need to look after those children, it's the priority, and not us the priority, it's not the priority. Anyway, I know that's cheerleader telling me, but I believe in it 150%, and that's why Ibrahim was put on the council your nurses are so important to your family, for your kids. So important. The nurses are the most important. They are the protector of that child. So listen to your nurses and don't be offended if they say something to you. And you're a doctor. Don't be, okay? Yalla? So you're gonna do this? Okay.
So I'm just asking about the ego in the States, is it the same?
It's horrible.
Everywhere.
Yeah.
Everywhere is ego. But there's, when I first started doing this, I remember one of the doctors, he was a young doctor in the ICU. American doctor, American nurse. And he told me, I said, I saw this great before. And I thought, wow, that's so great the way the nurses say, I don't touch, no, did you check the dosage of that? And the guy said to me, that nurse over there, she saved my career because years ago, I was exhausted. I had double the dose of, I don't know what it was, potassium or something. And I was gonna kill that kid. And she said, did you check that? Because I think you just did you did it. And he looked, he said, my God, you're saved, She saved, and that was, and I thought that's the thing, the camaraderie, is the thing between the two of them, because they help each other. It's a very different dynamic in the United States. But you guys are gonna get to that point. I know you will. You just have to respect the nurses and respect each other with what you each know, so. All right, I really believe, yeah, so she knows that, whatever, you know that. But that was really a great presentation.
We really thank Dr. Natalie. You're in a great need for this, especially if it was a very useful interaction.
Yeah,
And this is all about.
Yeah.
It's all about the interaction.
right.
So like, Mahara said, that we need to have champions, we need to have, yeah.
You should assign, you should ask if anybody wants to volunteer as being like a hand washing champion, a central line dressing champion.
Yeah.
You should ask them if they want to volunteer, and if you don't get volunteers, then you should say, okay, you should watch, and say, well, that person so good at it, will you be our champion? You know, and that's a nice thing for them, because they get proud of their accomplishments.
And we may have, so for your, can we say, maybe? So we may have an advancement on our ability to detect organisms quicker. So everyone knows the system we use now is the blood culture bottle that's called the BACTEC. When that signals the machine that something's positive, they can do, the first step is a gram stain, and then they do the culture. So in this new system with the BioFire, when you get the signal, they can take that right away and put it on the machine, and in 1 to 2 hours, you will know what bacteria it is and what the resistance, if it has a resistance gene. So our laboratory director has worked directly with the COO to be able to purchase this machine for you all, for your patients. And we're hoping to institute it, hopefully, in the next couple of months. So congratulations to you. Advancing.
Actually, Mr. Ayman has donated it since tomorrow.
Since tomorrow. Wow.
Donated from his own, and he ordered it to be here in 24 hours.
Oh my
So
God.
this is a personal gift.
Unbelievable. So if we get those results while I'm still here, we can talk about how to interpret them. Thank you so much, everybody. Have a great day. Thank you. Thank you.